All right. Hello, everyone. Thank you for joining us this afternoon. I want to take just a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this webinar. You can activate that by clicking the interpretation icon on your Zoom navigation bar. If you need any technical support during today's webinar, just send us a message in the chat and one of our hosts will address that for you and assist you with that support. Lastly, if you have questions throughout the presentation, please use the Q&A feature also in your Zoom toolbar. Those questions will be sent directly to the presenters and the moderators. Next slide. All right, I want to take a moment to note the views expressed in written conference materials of publications and by speakers and moderators do not necessarily reflect the official policies of the U.S. Department of Health and Human Services and SAMHSA, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. SAMHSA has selected Altarm to provide training and technical assistance support to states, territories, and tribal organizations and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix, who have extensive experience with crisis services and technical assistance. The CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. Next slide. I do want to take just a moment to provide some acknowledgments to our SAMHSA partners, Jill Mays, who is the Division Director at the Crisis System Transformation Office, as well as China Locklear, who's the Public Health Advisor for this 988 Crisis TTAC as well. Next slide. So just a quick overview of what our agenda will look like today. I'll give a little bit of information about backgrounds and bios for our speakers. We will talk a little bit about the core elements of recovery in children, youth, and families within the crisis system. We'll talk about youth and family guided strategies, as well as dive into mobile response and stabilization services. There's going to be an opportunity for us to have a Q&A portion where we'll address some of the questions that was submitted during your pre-registration and any questions that come up during the webinar. And then following the Q&A section, we will transition over into office hours, and then we'll wrap up for the afternoon. Next slide. So giving an introduction for our first speaker, Gail. Gail is currently the Director of the Technical Assistance for the National Federation of Families. She's serving in this role for a 5-year grant period. The National Family Support Technical Assistance Center essentially is focusing on supporting families and caregivers of children, regardless of their age, who experience serious mental health issues and substance use disorders. Next slide. Our second presenter is going to be Elizabeth Manley, who is a nationally recognized for her expertise in children's behavioral health, alongside intellectual and developmental disability and substance use, systems design, policy, and financing. And with that, I am going to transition over to the next slide and hand it over to our first speaker, Gail. Welcome, Gail, and thank you so much.
Hi, thank you for having me. Today we're going to learn a little bit about who the National Federation of Families is and how we support the family peer workforce. Next slide, please. So here's a little overview. Who we are. We're the National Federation of Families. And I don't know if you've heard of us before, but we've been here for almost 38 years. And we're going to identify when and how to collaborate with families to promote recovery. And this is really important because as we go through the crisis system, we're really going to learn how and why a family peer specialist is an important person in that crisis system. And of course, we'll talk a little bit about our national certification and how we use that to expand and grow the family peer workforce. We have a few national campaigns that we're really proud of, and we'll talk to you about my favorite piece, our annual national conference. Next. So who are we? We are the national family-run organization that serves as the national voice for families of children who experience mental health and or substance use challenges across the lifespan. And I don't know about you, but I'm a mom and I have a 41-year-old and I have a 38-year-old and a 28-year-old, all who have had mental health challenges in the past, but they still do. And it doesn't magically disappear at 18 or 21. You know that it's not, I'm cured yet. I was a child with mental health issues and behavioral health issues, but now I'm fine. That's not how it works. And you know, even when your 41-year-old child will call and that phone will ring, as a parent, my heart skips a beat. So we decided we needed to really support families through the lifespan. And what is a family-run organization? Well, 51% or more of the board of directors must be family members. Staff must also be family members. Our executive director on down, all are family members who have had lived experience being a primary caregiver of a loved one. We support families. We, of course, promote family peer support. And you know what? We believe that families are the experts. And I don't know about you, but I know when I look at my child, even to this day, I can tell if they're coming down with an illness. I can tell if they're upset, and they don't even have to say a word when they walk into the room. Next, please. So this year we have an overarching theme that I'm really excited for. And if you get our newsletter or you get any kind of flyers, you will see that we are really focusing on keeping families and children and youth in their communities and being supported in their communities. We really believe that if we strengthen family stability, we promote healthy child development and ensure children can grow safely within their communities rather than in congregate care settings. We believe they belong at home or as close to home as possible. And you know what? This commitment is going to be something you're going to hear over and over and over again this year from the National Federation of Families. And we're even going to do our conference really based on this theme. So our theme, this is exciting. We just changed the name and we're just promoting it. It's going to be the urgency of now, ending isolation by creating effective community ecosystems. And that is also what our Children's Mental Health Action Week is going to be all about. And we're going to really learn in the month of May how watching kids with social media and being online, how we can support children and youth and adolescents and families to know that that's good. We are all online. But if we limit that, we can create a healthier environment that really talks about communication and safety and keeping kids home in their community. Next, please. So how are families critical to the success of individuals in their recovery-oriented care? When services are family-driven, and that means when we really focus on what the families say they think will work best and not what services are available, they are more likely to succeed. Individuals are quicker to engage in treatment. When families and children and youth are really knowing that you're listening to them and they have some support, they are quicker to engage in treatment. And that's clinical treatment, of course. Individuals are quicker to graduate in the program. And also in this day and age, we can talk about how cost effective that is. That if people engage and understand the treatment and really know it's the treatment or the services and the supports that they identify they need, it will work better. It's more effective. Next, please. So what is family partnership? Family partnership is a family engagement process. It is a collaborative and strength-based process through which professionals, families, and children of all ages build positive and goal-oriented relationships. It is a shared responsibility of families and professionals at all levels that requires mutual respect for the roles and strengths each has to offer. And this is important to really think about. When we have families there, they're the center of our attention, the families and the youth we're working with. But the support staff around them, whether it's a clinician, a psychiatrist, or a family peer specialist or a youth peer, we should all look at them not as a hierarchy, but as an equal group, a team that respects each other and really works together in an equal way. That there is no, gee, I want to grow up to be a clinician someday, I'm getting promoted. We should all really look at ourselves at a level playing field, that we're working for that family and we are one team. Next, please. Families' lived experiences, expertise. And that is true with the family peer specialist too. That lived experience is worth a degree. In many, many cases, you have worked with families and you've navigated your own family in crisis situations, and you've been doing it for 5 to 10 years. That is an education that is invaluable. So where can clinicians and other workforce start? Use understandable, strengths-based, person-centered language. We should all be able to really use that strengths-based language. We need to get on the same page and share knowledge and share ideas. And of course, we plan for respectful conversation, intentional meetings, and positive conflict resolution. And remember, intentional meetings. Let's not just have a meeting to have a meeting. Let's make sure when you have a meeting, you have a plan and we know who is doing what as we go forward. Next page, please. So the benefits of a family-driven plan. Well, of course, it improves relationships not only between staff and persons that are serving the families, but it improves the engagement process and the feeling of being supported to the families. Increase staff satisfaction, and of course, decrease turnover. If we all look at each other as teammates and not as a hierarchy, as I had stated, there's a lot of respect for the job and a lot of work satisfaction, and we all want to know we're doing a good job. That does decrease turnover. Increased individualization and overall quality of plans. If we're person-centered, if we're family-centered, and we're really listening to what that family and what that young person really says they need to be supported, that's going to be the best quality of a plan. Greater engagement in services, decrease in crisis events and high intensity service use. So obviously, when people are working the plan and they feel good about the plan and the family realizes it's their plan, not a plan put upon them, it's going to work better. Next page, please. Here's a couple of things that you can take with you to go to your own office. We created a family partnership checklist with our partners from Boston University. And it's a checklist that you can find on our website, and you can print it, you can share it, but it lets you kind of self-reflect on whether your organization is really being person-centered, family-centered, and you are creating that family partnership that will lead to family engagement. So I encourage you to really print that out and use it. Next, please. And now this is my favorite map. This is on the National Federation of Families website. And the National Federation of Families is the national organization, but we have about 72 affiliates in all over the country. And an affiliate is an independent family-run organization with an independent executive director. We just provide technical assistance when they ask, and we like to bring executive directors and the workforce together and bring family leaders together, but we do not oversee the organizations themselves. They're all independent 501c3s. But you can go to any one of these states and click on your state to see what family-run organization is there, and you'll know that they're an affiliate of the National Federation of Families. And you will also know you can get um, real information for your community in that area, because the family-run organizations really know what's going on, what's best practice, who to go to, how to navigate in their own communities, in their own state. And on that note, we had a question that was written in during registration of this webinar, and it said, where do we go when traditional treatment fails and family does not have the means to pay for private treatment or services or supports? Here's your map. If you go to the National Federation of Families map, you could direct that family to an organization in their state. And these are the people on the ground that can really help you figure out who in your state can help you with that. And another thing, a lot of our affiliates have family peer specialists. So you may have a family call, and guess what? They may be able to obtain a family peer specialist who will help them navigate the process. So that is even a bonus. And there's also other organizations, and I really think the local NAMIs in your state, NAMI National, but really the NAMI in your state, in your community is a great resource to look at and to ask what kind of services are available and what kind of support you can get. And there are so many community organizations, youth move in your area. I recommend you go to any of those in your community, because the national organization, we're great, and I can direct you to this map and give you a key person. But getting that person in your community will be the most helpful. Next page. So a family peer specialist. Who is a family peer specialist? It's a parent, a family member, or a caregiver who has or had responsibility parenting a child, or as a primary caregiver to another family member experiencing mental health and or substance use challenges. Now, you may notice, if you've been with the National Federation of Families for a while, that we've kind of expanded this definition. As we were working with the Center of Excellence before it was sunsetted, we really worked with SAMHSA to decide that family peers, we've always known, and I've always known, that family peers are usually parents or primary caregivers of children. But we're now learning that family peers happen to be sibling to sibling. I happen to have a sister who has a significant mental illness, and when she's in crisis, guess who her family peer specialist is? It's me, and I help her navigate, and I help her husband help her navigate systems. So we now have expanded the definition to family peers as siblings, as spouses, as children who have had to navigate the system for their parents. And that's a growing situation that we've heard about. And of course, family peer specialists can speak about and use their lived experience to support other family members, to advocate for their family members' well-being, supporting them in navigating the systems, and providing those necessary resources. No one's better at it than saying, hey, I walk the walk, and this is what I did. You don't have to do this, but this is how I managed, and this is what I did. Or even someone to say, hey, I get it, I've been there. That is such a relief to other families. Next, please. Peer support from those who have cared or are caring for a child across the lifespan with mental health and or substance use challenges really connect with families. And that reduces that isolation that I was just talking about. It also normalizes lived experience. And you know, when you realize that you're not the only one out there, what a relief. And it reduces shame and blame. And you know, as a parent, I think the day they put the baby in my hand, I became guilt. Oh my gosh. I was always worried about, will they blame me? Am I doing it right? The guilt and the shame I put on myself, and then to expand it to others who look upon you, we know we need support. So we often say we don't blame parents or family members ever, and we really need to reduce that shame and blame. And of course, encourage families to hold hope for recovery and access to support. Because, recovery is a long road. You may have a crisis. You may get a family peer specialist after that crisis or during that crisis, and things might level off. But you do know that every once in a while, things kind of fall through the cracks, even with the best of supports and services. So having someone there to be there as your support for that whole stretch is a wonderful thing. Next page, please. We have a great curriculum, and this was developed when we were the Center of Excellence before we sunset it. And we worked in conjunction with SAMHSA, and we developed a self-paced curriculum. And I believe they're going to put the link in here for you to access. But there is a general curriculum on what a family peer specialist is and how the competencies and the task and the skills you need to become a family peer specialist is in this. We also have different breakout modules that will work with how to be a family peer specialist if you're a sibling or a spouse or a child. So I really encourage you, if you're thinking of joining the workforce, which we always need you, please look at this curriculum and take it. It's self-paced, it's online, and you get 8 hours of a certificate for 8 hours so you can apply it to the national certification so you can be a nationally certified family peer specialist. Next page. So that is all I have right now. And here's how you can contact me or my executive director, Dr. Linda Goggin. Both of us are always willing to answer any questions you have. But right now, I am really pleased to turn this over to my friend Liz Manley. So Liz, take it away.
Thank you. Thanks for having me today. I am incredibly excited to join and to have this important conversation around the customization of crisis care for children, youth, and families. For those of you who don't know me, my name is Liz Manley. I'm a senior advisor for health and behavioral policy at the Innovations Institute. And I'm really excited about talking about children, youth, and families and the importance of really customizing the care for these young people. Next, please. So just a little background, right? Like it's important for us to ground in what the data kind of looks like. So there are nearly 20% of children and young people ages 3 to 17 in the United States have a mental, emotional, or developmental or behavioral health disorder. Really important for us to know just some of that, right? The 10% have a serious emotional disorder. There's suicidal behaviors among high school students has increased more than 40% between 2010 and 2019. And rates of emergency department visits for mental health has increased by 25% for children between 2016 and 2018. There's just a few of the data points that are really important. What's also important is that there are places in the country in which they have seen less utilization in emergency departments, more utilization of home and community-based services to address the needs of these young people. And we're going to highlight some of those best practices today. Next, please. Before we get started in crisis, we always ground in systems of care because systems of care allow us to really use the values and principles that drive the best practices for young people and their families. So family and youth-driven care, and you just heard quite a bit from Gail around how important parents are, how important parent peer support, youth peer support is within the crisis continuum. I'm just going to, echo that and say it's incredibly important for innovation that young people and their families have a big voice in terms of how the system is organized, designed, policy, decisions, and at the individualized care level. Really important in terms of the success for these young people and their families and for the states who are implementing these practices. We want to talk about the fact that the crisis system is really designed within the community-based continuum. Really important about that. It's really designed to interact with home and community-based services. It's also designed to ensure that cultural and linguistic competence is a high priority for the mobile teams. Understanding the communities that they're serving is really big priority for mobile teams. And that these guiding principles are going to drive how we do the work. In other words, we're going to center young people and their families in all of our practices to ensure that we're providing the best care for these individuals during the time that they're in crisis and through all the way through what happens next. Next slide, please. So these are the core components of the system of care. And before I continue, there's a couple things I just want to say around some of this work. One is, one that I think is really important is that when we're designing services and supports for children, we're not just talking about adolescents. We are talking about children. And it's important to understand that the continuum of care requires us to understand the developmental places in which young people are in and whether they're on that developmental path, and keeping them as close to that developmental path as possible is just a driving part of this work. So it's not uncommon for a children's crisis system to see young children 3, at 4, at 5, at 6. These are not, when the system is organized that way, it's actually a success that we see children when they're younger, because we want to reduce the amount of time it takes for young people to get the care that's necessary in order to meet their unique needs. Understanding that part helps us understand in building that system of care in all of its components that we're looking at organizing across multiple structures within state government to ensure young people are going to get their needs met in a way that is coordinated across those systems. In order to do that, we need actually a couple of really important structural points. One, we need a governance structure that says who touches in the lives of these children. How do we bring all of these people together to ensure that that the connections are made and that we're not approaching any of this work from a siloed approach. That mobile response and stabilization is a game changer for states. It's a customized way of providing crisis care to children, youth, and their families. That we have a comprehensive, evidence-informed service array that connects lots of the dots, both in the formal supports, but also organized to address the need for informal and non-traditional supports for these young people. That we use evidence-informed care coordination models such as high-fidelity wraparound to ensure that young people are getting their needs met in a way that elevates their voice and elevates the voice of their parent, their caregiver, their families. We use financing structures that are organized in a way that both recognizes the need for Medicaid, but also addresses blended and braided funding so that the service delivery is as seamless as possible for families. So that organization of the system in a way that makes access easier means that families will utilize those services in a more proactive way that will not have them entering emergency departments and inpatient care. These are all really important systemic care values and principles. We want to make sure that we're providing community-based services, that youth and parent voices are not just elevated and heard, but that they are driving and we're honoring their voice and choice. That there's cultural awareness, not just in the cultural of the young people who arrive, but recognizing the communities they come from, recognizes the that there could be cultural differences between parents and their children. It's just really important for us to understand all of that. We're going to balance system and outcome monitoring by making sure that we're paying attention to all the drivers of what success are, and that we're improving the lives of children and families, and that they're articulating that and helping us to figure out how that system can be operationalized and do more work for these young people moving forward. Next, please. This is just the pyramid of service needs. So what we know is that young people with intensive behavioral health needs, that 2 to 5% of young people, could be as high as 8 to 10% these days. And what's important about that is that that group of young people may need more intensive support, and they may need a connection to higher intensities of service. And that intermediate behavioral health group of young people, that 15 to 20%, may need some of those same services and supports. The challenge for us is we actually don't really know, even in a crisis call, who's who in this conversation. And so we want to organize the system in a way that's going to help us figure out what young people need for the duration they need, and what that's going to look like ultimately in the long run. It's also important to note that young people who have intensive behavioral need at the top of that pyramid are going to require more resources, and that requires more spending. So we really want to pay attention to what we're utilizing when and how to ensure the right young people are getting the right service at the right time for the right duration. Next slide, please. I also am a proponent for language matters. And what I mean by that is how we talk about young people and their families does matter. So in reorganizing systems and getting people to the table, bringing language to the most common level is really important. So we talk about children, youth, and young adults, not clients, cases, or consumers. We talk about parents and caregivers, not mom and dad, because they're not my mom and dad. So we're going to talk about parents and caregivers. We're going to talk with parents about how they would like us to actually engage and what names they would like us to use. A really important part of that work. We talk about families, certainly not those families. We talk about treatment and treatment interventions and not placement. And this is a really important concept. When I was the assistant commissioner in New Jersey's Children's System of Care, just changing that language, recognizing how, helping people recognize that we were looking for a treatment intervention that included a residential component, changed the number of young people who entered residential care when we shifted away from the idea of placement. Placement is where the young person is going to put their head on the pillow. Treatment and interventions are the things that will happen while they're there. And there is really important to know that there are both positive things that can happen within residential spaces, and there can be negative things that happen within residential spaces. Really important for us to balance those things. We work on engagement and not motivated. Anyone who's worked with 16-year-old knows that most 16-year-olds are really not motivated. It's our work and our real work within the system is to help young people understand why these interventions can be helpful. So a non-motivated young person or family just means we haven't found the right switch yet. And our job is to continue to work on engagement in order to get there. Transition is really important in all things in children's systems. So we talked today about long-term services and supports, and I just want to put this into really context when we talk about children. When we talk about the work with children, we're talking always about transition planning and what will happen when the young person completes whatever intervention it is. And the long term is relative when we talk about young people in general. Most young people can manage about 6 to 9 more months of intensive interventions before we begin to lose them. So really important for us to understand those pieces. It's also why it's so important to work with all of the adults in that young person's life, because we only have that short window of time to work with them. But we have longer periods of time to work with parents, to work with caregivers, to work with their schools and their communities to make it safe for these young people to be in their own home schools and communities. I want to just talk for a minute about young people who go missing. If a young person is not where we think they should be, if they, we are looking for them, but we cannot find them, we're going to say that they're missing and not run away. What we know about young people who get, sort of pigeonholed into that terminology of runaway is that law enforcement doesn't look for them. No one goes to find them, to bring them back, to find out why they were missing in the first place. And it's really important for us to understand why they were missing in the first place. There's lots of reasons why young people go missing. Some go missing thinking adults are going to actually care where they are, find them, bring them back. These young people we must go find, figure out why they're missing and bring them back. And just that small work alone, by shifting language, we actually change how the adults interact with these young people. And I also just want to talk about family time. This is specific to any kind of program in which young people go. We want to make sure that there's family time, not home visits, not, that there's no blackout periods, that anytime a young person is in any type of bed, we want to ensure families are right there with them for as long as they can be in the most supportive environments. We also just want to put that resistance and manipulative behavior are two words that I don't use in my vocabulary because they're not helpful in trying to figure out how to help young people and their families. Next, please. Customizing for young people and their families just requires us to do a couple of really important things to make the system organized in a way that makes sense. One is we want to make sure that we have this understanding that we're meeting urgency with urgency. Parents and caregivers do not call a public system to ask for help unless they need help. And so our job is to provide that help. We don't know what the help is that they need until we ask the questions. We don't know what it's going to look like until we just go. So in the customization of the crisis system for children, youth, and families, it is predicated on the idea that we are just going to go hold the hand of that parent, figure out what it is that happened. We're going to organize in a way that we get information that's going to help us figure out whether that child's in that top tier of having complex behavioral health needs, whether they're in a moderate space, or whether they actually have a low-level need that requires a different kind of view. We don't know who they are until we go. It also prioritizes this understanding that safety and de-escalation and stabilization can happen in the home, school, and community. Stabilization in the children's space always starts with home, never starts with leaving the home. And there are a lot of reasons around that. So it's just really important for us to put that ability to understand what the unique needs of children and families are into perspective. Next slide, please. The core elements of the children's behavioral health system include a single point of access. And what that means is that someone's answering the phone 24 hours a day, 7 days a week. Now, some of you might be thinking that's a lot. Really, how many calls do you get in the middle of the night? But I just want to turn that around for a second and ask this question. If you are a parent who's feeling the level of anxiety and urgency because you are worried about your child and you call the public system in the middle of the night, how comfortable are you with that public system when it doesn't answer the phone? And do you think, I'm going to take my child to the emergency department because they're open 24 hours a day, 7 days a week? In other words, if we want to change the way that young people and families access the system, we actually have to be available to meet urgency with urgency. We want response teams that are actually trained to work with children, youth, and families. And as I said before, we're talking about children, could be as young as 3, who are really calling for assistance within that mobile response world. So it's really important that we have individuals who are trained to work across that child serving system. That we have a single assessment process. We're going to use the same tools across the system so that we begin to have the system speak the same language. There's a lot of efficiency and effectiveness in terms of just that part of moving to a single tool where everyone can actually begin to speak the same language. that we use in-home stabilization services and supports, intensive care coordination using high fidelity wraparound as its practice model, crisis stabilization centers only when we've determined that the young person cannot be safe in their own home, a continuum of outpatient and intensive outpatient services that we're also clear the young person is ready for and can benefit from. So the sequencing of care matters when the young person accesses outpatient, that they know what will happen. They're prepared for that intervention because outpatient can be very intensive for some young people. That we have a full residential continuum, and that residential continuum really highlights trauma responsive care and as actually focused on residential best practices, including building bridges to home and making sure that parents have access to their children 24 hours a day, 7 days a week. They're actively engaged as partners within the treatment teams. And that respite, mentoring, and skill building all built into the continuum. Next slide, please. This is the 2013 bulletin. SAMHSA CMS sent a bulletin to the Children's Behavioral Health Directors in 2013. This arrived on my desk in 2013 and basically said, these are the services that we know work for children and should be embedded in your Medicaid plan. So all the things that I'm talking about today, or a good majority of the things I'm talking about, are really available in the Medicaid plan for these young people. So it's really important for us to begin to think about how do we make sure that we have all of these components within our Medicaid plan. Next slide, please. Also, one of the challenges we have in the children's system, and all of you who work in children's services probably know this, that we have a very siloed approach to funding, right? Funding drives a lot of the service delivery for in some states. In other words, you can get this if you're included with child welfare, and you can get this if you're in juvenile justice, and you can get this if you have Medicaid, but you can't get that if you don't have this Medicaid plan. If you can go to the next slide, please, that would be really helpful. The next slide, this slide basically says, we should be able to access what service we need for a child, regardless of where the funding comes from or what silo is controlling it. And it's really important for us to build the service array in which we can pick and choose what it is that a young person's going to need, what is going to support their parent and their caregivers so that we can keep and maintain these young people in their own home, schools, and communities. Next slide, please. So the children's system goals are not complicated. It's to maintain the child within their own home, their own schools, and their own communities, to support the youth and families, really using trauma-informed care, recognizing that healing environments are in those the home and school, that setting those the home and school up to actually address that trauma for young people is the precursor to formal intervention. So it's really important for us to understand what those teams can do to help begin building that trauma-informed environment for these young people in their own homes. Promote and support safe behavior in home, school, and community. Reduce the use of emergency departments, hospital boarding, and detention centers due to behavioral health crises. We do not want the detention center to be the largest behavioral health system within a community, and yet there are states in which that is true. We do not want young people boarding in emergency departments. We don't want them touching in emergency departments because that it can be a traumatizing event for these young people. Inpatient care is a necessary step for some young people and helpful within the continuum. So we really want to be thoughtful about when and how inpatient is used, outpatient is used. We want clarity on when and how. We're going to assist youth and families in accessing and linking to ongoing support and services, including intensive care coordination and in-home services as necessary. Next slide, please. We're providing, and I've said this before, it's really important for us to get this piece right. Right service, right time, right duration. Many young people end up in higher intensities of service than is necessary to meet their clinical needs because lower intensities of service don't exist. And it's important for us to pay attention to when and how that works, because anytime a young person ends up in a higher intensity of service than is necessary, we can do harm. And that harm is not short-term harm. That harm can be long-term and have long-term impacts. So even if inpatient care is necessary in order to meet the needs for a young person, we must mitigate against that. We must actually have conversations about why that is necessary. Next slide, please. Single point of access is really important for us to pay attention, right, to how young people really are going to access care. One of the biggest challenges families have, right, is where do I get help? Even in systems that are really logical, right, and make sense, it's still difficult for families to figure out, how do I call that 1877 number to get help? Because you have to make sure everyone knows that that's the number to get to on a particular day, that they need that number. So when systems are organized with numbers all over the place and no really systemized approach, a no wrong door approach to driving to the right service, families get frustrated and they get overwhelmed. And so it's really important for us to use a single point of access to make sure that the young people are getting what they need at the time that they need it for the duration. That single point of access is going to do things like screening for worrisome or high critical need behavior, making sure that help is going to get there as quickly as possible. It's going to deploy teams. It's going to make sure that the child welfare system can access the care that is necessary for children. So it's just really important for us to pay attention to the single point of access. And if it doesn't exist, to begin thinking about how can it exist. Now, one thing that's really important in this conversation, single point of access must have the ability to actually listen to parents and deploy teams in a just go model. Parent calls, asks for help, nothing else. We're sending teams. We're going to have that team go. Next slide, please. Mobile response and stabilization is the customization of the crisis continuum to meet the unique needs of children, youth, and families. It is a rapid response, home and community-based crisis intervention model, and it's really important that we understand how powerful it is in the service delivery system for children, youth, and families, because it does things like help parents see that they can get help quickly, that help is individualized, that the help is in their own homes, that help is designed to get the child back into their activities as quickly as possible, that it organizes what's next for these children, and it sequences care in a way that says, we're not ready for outpatient. We have work to do to get to that place. So we're going to make sure that this young person is supported with community activities. And those community activities are prepared to help these young people move to get ready for those formal interventions. So it's really important to understand how transformational mobile response and stabilization is for children, youth, and families. Next slide, please. And I can give you just a real quick example of what I mean by how important it is. In New Jersey, mobile response and stabilization is dispatched for every child who enters foster care from the age of 4, actually it's 3, 3 and up. If they go into foster care, there's a mobile response team that meets them and spends time with them, really doing simple things. Something big just happened. Because something big just happened, might have a hard time eating, sleeping, paying attention, school might feel real different. When that pilot project went into place in New Jersey, the average move for a child in foster care with a behavioral health need was 6 moves. That first pilot, 46 out of 46 of those children stayed in the first bed they went into with 0 behavioral moves, only planned moves. It's because it's important to highlight, bring attention to, understand when a young person has experienced a traumatic event like the removal of their home and movement into foster care. Here's the grounding components. It's response within an hour, has capacity to respond with two-person teams. It's not always necessary to have a 2-person team when you're working with children. There are circumstances where it's always necessary, in some circumstance where it's overwhelming for families. It responds without law enforcement as a rule. There's no law enforcement co-responder. That doesn't happen. There is the use of law enforcement only under the circumstances in which there is a high level of danger because there's a weapon involved, and it is the responsibility of the team to ensure that the parent understands that law enforcement might be necessary and they're in agreement with the use of law enforcement. It allows for multiple 24/7, 365 in-person responses for up to 72 hours as necessary. It provides a warm handoff to identify the services and supports and pre-existing care coordination or referral to stabilization services when necessary. So really important components within that MRSS space. Next slide, please. Customization for care, and I'm just going to move through this pretty quickly, just really highlighting that crisis is defined by the parent or the caregiver or the young person themselves. It's just go. They ask for help, you send it. It meets urgency with urgency. It's a non-law enforcement response. There's an assessment that's attached that helps us understand what next. And that stabilization is always first thought of for young people within their own homes. Next slide. Stabilization services is provided in the home and community. It's evidence-informed care coordination. So there's a care coordination component to stabilization in that mobile response and stabilization model. And then there's clinical services that are available for the young person in there. And it can be clinical services, it can be supports, skill building type of supports in home for the child, youth, and family. And there's a connection to higher level of support if necessary. So movement to intensive care coordination, high fidelity wraparound for some of these young people as necessary. Some of these young people might end up in traditional services like outpatient, intensive outpatient, but not necessarily all of them. But they all need community connection, re-engagement with school, engagement with activities, and really significant engagement with the parent, caregiver, and family. Next slide, please. And this is really a system to support these young people. It generally speaking, stabilization services is up to 8 weeks. It's usually between 6 and 8 weeks of stabilization for young people who need additional support post that response, that 72-hour response. It includes this ability to understand more broadly what's going on for these young people. It's really setting the stage for the family around what other services and supports might be necessary post-transition. For some families, this is enough. They're good, they're ready to move. For some other families, they're going to need additional support. And that additional support is really important for us to pay attention to. Next slide, please. In-home services includes care coordination, clinical supports, respite care, and skill building. That's really what it is. And it's a package that happens, mobile response and stabilization team, and that stabilization service package are the same team that's working, right, with additional community partners around that. That's how it's organized and designed. Next slide. Factors associated with evidence-based care coordination. So it's important to know that there is evidence-based care coordination, that it makes it, that we use individualized, that you use the family's own ideas, that you're building hope, that you're working on a plan that's going to get monitored and updated as necessary. It's time limited, it's comprehensive, and it's important to know that there's building of those teams is really important. So it includes young people at that table, and it includes parents, clinicians, and professionals. Do not plan or do a plan without the young person in the family having a large voice within that planning process. Next slide. Intensive care coordination is high fidelity wraparound delivered within child family teams. It includes peer support. Peer support is both a way of doing care coordination, but also a partner within that high fidelity wraparound team. that there's community development and engagement that happens, and in the behavioral health home space for children with chronic medical conditions. Next slide. Systems coordination. So this is the other thing that makes children really different than adults, right? There's all of these systems that are working with young people. You have child welfare, education, you have juvenile justice systems, you have family courts, which operate very different than adult courts. You have pediatricians, and many young people have a connection to their pediatrician. It's who the parents have talked to before, even calling for assistance and help. So it's really important to understand that there's coordination in that child serving space. And then there's the engagement with emergency departments, community organizations that work with children, understand children and families. And this understanding that we need a real clear partnership with law enforcement. Ongoing engagement, training, support with law enforcement is one of the core components of mobile response and stabilization. Next slide, please. There's a brief, a safe place to be that really highlights best practice when it comes to the crisis response system for young people who require a higher need, maybe out of the home, that includes stabilization centers. I encourage you all to take a look at it. It's really a great brief to understand that particular part of the continuum and how important it is. It is an important part of the continuum. It's just not for the full population. It's going to be for a very specific population of young people who require that stabilization service not to happen within their own homes. Next slide, please. You really have to collaborate. Like in children's systems, you got to work with people. You got to talk to people. This is why we bring our language down to the most common level. We have to work with our child welfare and our juvenile justice partners in the school systems. And just as an example, they all speak different languages, right? So they, in juvenile justice, you're talking about juveniles, and child welfare, you're talking about cases, and school systems, you're talking about students. So we have to really take that language to the most basic common denominator and work through how it is we're going to organize and speak to each other in a way that's going to be most efficient for children, youth, and families. Next slide, please. And then we're going to root in quality. In other words, we need to know, are we successful? We're going to have benchmarks. We're going to report publicly. We're going to seek ongoing feedback from young people, families. The system always has to organize in a way in which it's really understanding how it's going to grow, shift, change over time. Next slide, please. And these are just some of the outcomes, that are really important for us to pay attention to. And I'll just say a couple of them that I think are really important. When residential is used, how often, is it short? Does a young person return back to their homeschooling community and do well? That is a good sign of residential intervention being done well. Do young people graduate on time? What are the suicide rates within your community? Is there a high use of law enforcement for young people? And are you overutilizing the emergency departments? Next slide, please. So in children's systems, we really have to have a level of leadership that helps to drive some of this work. And what I mean by that is, in the large behavioral health systems within states, children's behavioral health is a very small component. But it's necessary for leaders to be included in these important conversations, because many of the young people, adults who have complex behavioral health needs in the adult world, started as children. They started in the children's space. They have unmet needs from the children's space. And so we need our children folks to be at the table to say, hey, we can help you there if we can sit at your table. So you really need some leadership skills, because we have to create the conditions that allow for shifts in language and practices necessary for parents to reach out for assistance. That requires us to help our single point of access know they have to just go, that it's not a debatable point. So we have to build the resources and the tools in a way that makes sense. We have to prioritize the voice of young adults, of parents, caregivers, of young people, and we have to keep them central in the planning we can never lose sight that this is all about young people and families. We have to create feedback loops, and we have to hear not just the good stuff. We have to hear the stuff we don't want to hear. We have to fix it. We have to fix it in a way that is meaningful, and the systems need to be logical. They need to make sense. They need to be easily accessible by the folks who are going to actually need those services. We need to engage communities in supporting children and young adults and create fairness across the workforce, focus on interrupting care pathways that lead to restrictive services. And I'll just say this from my own experience. And when I work with states, I tell all folks in states, if you do this work well, everyone must change. Everyone must change, right? So we must change our own practices. We must change the way that we think about young people and families. We must coordinate with people that we probably don't want to, but we need to. And we need to keep coming back to the conversation and make it right. Next slide, please. Lessons learned. These are my lessons learned. Relationships are key. And so we have to keep coming to the table, and we have to make sure that we're building our relationships, not only with children, youth, and families, but with our partners within the work, our colleagues, all of the people that are really in the world that can be helpful for us. Engagement, engagement, engagement is the key to success with young people always. There is a switch for them. We just don't know what switch it is. There's 100 switches. We have to turn them all to figure out how young people are going to be engaged. And it is our job to do that. Language shifts in practice, right? So if we change our language, we will see the shifts in practice. We need to share information, and we need to share broadly. And what I mean by that is all of the lessons that we learn, all the tools that we know, don't let other people have to redesign it, share what we know. We connect in community, and community connection is really important for every single young person and family that we work with. And so our job is to bridge to community, bridge to the folks in the community that can be helpful. That means we have to bridge to those communities. We have to know who they are. We have to go explore the communities that we serve. And we have to understand the data. We have to share the data, and we have to talk about it. And then we have to communicate. When I worked at DCF in New Jersey, someone asked me what my job was. And I said, my job is to say the same thing 5,000 times a day, every day, and then come back and say it again 5,000 times a day. We have to communicate in a way that people can hear us, and people have to hear the messages over and over and over again, in particular when we're shifting and changing systems and systems design. So we have to show up and communicate in a way that people can hear us. And we have to really pay attention to whether or not they did. In this work, we have to listen twice as much as we talk, although you didn't get to see that today. But it's really important that we understand what the impact to the people that we're trying to serve is. Next slide. Just two things on this slide. I just want you to know the TA Telegram is a really great newsletter. If you're not signed up for it, please do. I think you'll get a ton of information about what is the resources that are available to all of you. And if you're interested more in MRSS in particular or other things, if you go to Innovations, we have a ton of information around MRSS specifically, but certainly some other things that you might be interested in when it comes to building children's systems. I think that's my last slide. Resources for all of you. Oh, that's my name and my my email. Please reach out if you have any questions that we don't get answered today.